Thank you for the opportunity to speak about autoimmune encephalitis today. I will discuss various cases and try to convey some information to you about this new increasing disease. My disclosures, I don't think they will impact really the content of my talk today, but you can see them here. As already discussed by Dr. Efberger, autoimmune encephalitis is not a novel disease. It was already known in the 50s and 60s, and in the 80s there were syndrome descriptions, and the initial antibodies discovered. A hallmark of those antibodies discovered was that it was about rare diseases, and that the antibodies were mainly a biomarker for a paraneoplastic disorder related to cancer, and that most patients did very poorly on immunotherapy. So you could manage to treat the tumor, but unfortunately the cytotoxic T cells creating the immune response in the brain did a lot of damage, and therefore the deficits were permanent even after successful treatment. And I would like to start with one case. It was a 65-year-old woman I saw a few years ago with 2 months of progressive diplopia. She had vertigo and nausea. She was very fatigued and developed dysarthria and a tremor of the face. She had progressive walking difficulties and somnolence. She developed apneas with respiratory insufficiency, and she required intubation. Therefore, she was transferred to our ICU in my center. She had a non-relevant past medical history, no medication, but she had been an active smoker for 40 years. On neurological exam, she was alert, but she had some problems with her eye movement. She had a opsoclonus of both eyes. She had a facial diplegia and also an action myoclonus of the face, which was very painful to her. She also had hyperexplexia, so if you startled her, she would develop this myoclonus of the face and also trismus of the jaw. She had a proximal paresis of the arms and legs and some ataxia, more prominent on the right side than the left side. We did some workup. EMG was done for myasthenia in the initial phase when the opsoclonus was not so prominent. An MRI was done, which was completely normal. Also a lumbar puncture, which was completely normal. And blood results were also non-revealing, with no antibodies, no signs of sarcoid or lupus. Paraneoplastic panel was negative, and she had a normal CT thorax abdomen. But then we did examine the CSF for antibodies, and she turned out to be positive for anti-Re, which can cause a stem encephalitis, which was similar to what our patient was suffering from. We started with plasmapheresis and also performed a PET scan, which revealed a small nodule on the right lung, which was then resected and turned out to be a non-small cell lung cancer. On hindsight, this small lesion was already visible on the CT, which was performed a week before. She also started with IVMB following surgery, and this patient recovered very well, and within 3 weeks from admission she was discharged home, not even to a rehab clinic but discharged home, and she remained much better for a long time. So what can we learn from this first case? CSF can be normal, and in that way encephalitis is not always the encephalitis we know from infectious diseases. The antibodies can be present only in CSF, and especially Re is known for being difficult to test, so can be missed in serum. And we will see some cases later in this talk where I also show some difference between serum and CSF. In specific cases, FDG PET can have additional value to CT, although often it also is a help to detect small changes already visible on CT in hindsight. The tumor treatment is essential to stop the inflammation, and often we have discussions with oncologists where they say that the patient is not in a good shape to receive treatment for their tumor, but we have to remember that all these trials are done for Karnofsky performance scores based on the pulmonary condition or the gastrointestinal or systemic condition, and this way the neurological condition is directly caused by the paraneoplastic syndrome. So if you would wait for that to improve, you would get into a catch-22, and therefore it's essential to stop the treatment, to stop the inflammation process, and that's the only way you will be able to stop the neurological deterioration and even have sometimes improvement. In general, classic paraneoplastic syndromes like HU or YO or RE have a poor prognosis, but not always, and some patients, especially in MA2 or RE, can improve after and due to the treatments, so it's worth the efforts. But there is a reason why the interest has increased over the last 10-15 years, and this is because of the discovery of new antibodies, and the main discovery has been the discovery of anti-NMDA receptor antibodies in 2007, and this has been followed by the discovery of more than 50 new antibodies, and even this year there have been some new antibodies discovered. And the main difference between the old and the new antibodies is the location of the antigen, and this has already been discussed by Dr. Höfberger, but the old paraneoplastic syndromes had antibodies against antigens that were located inside the cell, and that could only be reached after the cell had been destroyed due to an immune response, and therefore it's more like a biomarker for ongoing destruction and inflammation, but not a direct interaction between antibodies and antigens while the cells are alive. The new antibodies, like the NMDA receptor antibodies, can directly interact with the NMDA receptor, which is located on the surface of the cells, and therefore can have a direct functional effect without the need of the cell to be actually damaged structurally. And this is very important, and maybe the most important difference between the types of antibodies and the prognosis of your patient. So if we go to the second case, which is a 17-year-old girl who started to behave oddly when she was on a school trip. She was behaving badly towards her teachers, also being rude on WhatsApp, becoming paranoid. And over days she started to behave more and more strange and started to speak less. She also complained of headache, and she was admitted to psychiatry for a probable first psychosis. She was started on antipsychotics, and she developed almost within a day extrapyramidal side effects due to the haloperidol she'd received, and also some catatonia. Then she developed a tonic-clonic seizure, and there was a neurologist was called, like, okay, could this be something, not a primary psychosis, but a secondary psychosis due to neurological or systemic disease? She had no fever, and she had a normal CT scan and normal CSF, but due to the subacute onset, she was considered to have herpes simplex virus encephalitis and was started on acyclovir. The MRI was done and returned normal, and also the PCR for HSV returned negative. And therefore, as it was, the symptoms had been present for more than 72 hours when the lumbar puncture was done, it was considered no herpes simplex virus, and acyclovir was stopped. EEG slowed slow waves, mostly in the temporal region, and not a generalized slowing. And she was considered to have anti-NMDA receptor encephalitis, and antibodies were sent for determination. But of course, it will take a while before you get those results. So a few years ago, we designed these criteria to say, okay, if you have excluded some important things like herpes simplex virus encephalitis, and you fulfill certain criteria, then you can say that it's probable anti-NMDA receptor encephalitis, and you don't have to wait for the antibody results to at least start the treatment. And if we look at those criteria and we look at our girl, she had a rapid onset of abnormal psychiatric behavior, speech dysfunction with especially reduction and mutism. She had seizures and a movement disorder with rigidity, maybe due to the haloperidol, and also an abnormal EEG. So therefore she fulfilled the criteria, and we started her on immunotherapy. If we look at NMDA receptor encephalitis, she fulfills the criteria for the typical patient. She is female, she's young, the median age is around 20, and 1/3 of the patient will have a tumor, which is most likely to be ovarian teratoma. There are a few caveats. In young patients under 12 or over 45, the 90% female predominance is less outspoken, then it's more like 60-40. In patients under 12, the rate of tumors is much smaller. It's very rare to have a tumor, actually. And over 45, ovarian teratomas are not frequent anymore, and you have to look for more like the typical carcinomas like small cell lung cancer or thymoma. If we look at the clinical phenotype, it's often starts with a viral prodroma for a few days, and then the patient starts with psychiatric symptoms like our patient with delusions, agitation, and change in speech. Especially the speech seems to be quite specific to this disease. Also insomnia, and then patients progress to have movement disorders or seizures and can continue into a more severe disease with severe dysautonomia and hyperventilation, which necessitates ICU admission. This can take weeks to months, and in the end, patients do improve and then remain with prolonged deficits, which can be cognitive or behavioral. And this, unfortunately, is the period that takes the longest, and the time of recovery takes much longer than the time of initial deterioration. It's generally a severe disease. Original figures show that about 3/4 of the patients will get to the ICU, and most patients, 87%, will have a modified Rankin scale of 5, which means that they're completely dependent on others for their care. And what we can also see is that only less than 5% will have only 1 or 2 symptoms like psychiatry and seizures, or only seizures. And most patients will have multiple different symptoms like movement disorders, loss of consciousness, autonomic symptoms, and so on. And this is important because I think every one of you will have the question like, okay, we have a psychiatric patient, is this anti-NMDA receptor encephalitis? What should we do to test it? And first, before answering this question, it's important to consider what we know about the test for NMDA receptor antibodies. We can test in serum and we can test in CSF. And what we do know is that the sensitivity of serum is less than in CSF, and the official figures say that about 85% of patients will show a positive CBA, but if we look at the figures for the commercial CBA, which is generally available in most labs, this is more like 70%. So 1 in 3 of the patients will be missed if you only test the serum. Also important, specificity. This is about 97 to 99% specific, and this seems like a very good test. But if we take, for example, the psychiatry ward, and we do a simple calculation, and we consider that, which is probably true due to, if we look at the literature, that 1% of patients with a primary psychosis will have anti-NMDA receptor encephalitis, and we take a specificity of 99%, which is a very good test. Then it means that the patient that is positive in serum only has a 50-50 chance of actually having the disease anti-NMDA receptor encephalitis. Therefore, CSF confirmation is essential. So when to suspect anti-NMDA receptor encephalitis in the psychiatry ward? I think it's about new onset psychosis, not so much in schizophrenia patients, and we have to be careful for subtle neurological symptoms, and most patients will develop more symptoms within the first 4 weeks of their disease. And also has been shown last year by the group of Oxford that most psychiatry presentations do not fulfill like the typical phenotype of one cluster of psychiatry symptoms, but it's more like a mixed combination of psychiatry symptoms. So what are red flags? Neurological symptoms, especially seizures, but also mutism, autonomic disturbances, fever, tachycardia or bradycardia, catatonia, extrapyramidal side effects on very low doses of antipsychotics already, and other autoimmune diseases in the history, probably also a red flag. And important, if you have a positive serum test, it doesn't mean you have the disease, but you have to confirm in CSF. And if you have a negative serum test, but you think this really is anti-NMDA receptor encephalitis, also do a CSF lumbar puncture to test for antibodies. If we look at the ancillary testing to help us in the diagnosis, most patients have abnormal CSF, but 1 in 5 does have normal CSF. And often the abnormalities are quite mild with only slightly increased pleocytosis. MRI is more often normal than abnormal. EEG is quite sensitive, 90% abnormal, but unfortunately not very specific. Extreme delta pressures have been described as being specific pathognomonic for anti-NMDA receptor encephalitis. That's probably true, but it's unfortunately quite rare, and less than 10% of patients with NMDA receptor encephalitis really have extreme delta pressures. So, going back to our case, our patient was treated by IVMP, but unfortunately she progressed and needed fixation due to her behavioral problems, then got IVIG also, and despite this treatment regressed to becoming mute and somnolent, and then the results returned back abnormal with NMDA receptor antibodies in both serum and CSF. We performed ultrasound and MRI of the pelvic region, which showed no ovarian teratoma, and then we were 2 weeks in, had treated her with IVMP and IVIG, but she showed no improvement at all. What should we do? So we can look into the literature, and we published this data a few years ago in over 500 patients, and looked at the outcome using the modified Rankin scale from 0 to 6, which is 0 for no symptoms and 6 for death. And what you can see is that if you have 0 to 2, that you have some symptoms, but you are independent in activities of daily living. After 24 months, we see that about 80% of patients have a good outcome as defined by MRS 0 to 2. Also, what do we know? Patients who do not end up at the ICU do better. Patients that start with treatment early do better. And it can take a long time before you really start improving. So you have to be patient. Also known is that patients that respond within the first week to initial immunotherapy, IVIG, IVMP, and plasma exchange, do very well. 97% has a MRS of 0 to 2 after 2 years. But also patients that do not respond within 4 weeks to this treatment of first-line immunotherapy, if you look at those, and those were the ill, severely affected patients, with most of them still at the ICU 4 weeks into treatment. And if you treat them again with IVIG or plasma exchange or a combination and so on, after 2 years, over 50% still had recovered to MRS 0 to 2. But if rituximab and or cyclophosphamide was added, this increased to 76%. And this, of course, has to be taken with caution, as this is not a randomized controlled trial. We tried to identify any bias but couldn't, but of course this could be part of the treatment effect, could be confounded by bias, but still if we look at this, we see that you have to treat about 4 patients to keep 1 out of a nursing home or death, which is quite a good response. Also important to try to predict the patients that do and do not recover well, and we developed the anti-NMDA receptor encephalitis 1-year functional status score using ICU admission, no effective treatment within 4 weeks, later treatment also defined as no treatment within 4 weeks, abnormal MRI, and a CSF plastosis over 20. And you could score 0 to 5, and what we can see is that patients with a low NEO score 0 or 1 almost all improve to an MRS of 0 to 2, while patients with 4 to 5 have only 30% chance of being MRS 0 to 2 within 12 months. This is not like a final outcome, but the outcome after 12 months. One issue there is that we use treatment response within the first 4 weeks as one of the criteria, so only 1 month into treatment you can determine the NEO score. But what we of course want is to do this at diagnosis, and for that reason we are now currently developing the NEOS2 score. If you look at our girl, she had a NEO score of 0 or 1. We were not 4 weeks in yet, so we don't know whether she would have responded within 4 weeks. And then decided to start rituximab, but just the day before we wanted to start rituximab, she started improving and improving quickly. And actually she could return home and had outpatient rehab as she improved that quickly. She received IVMP 4 and 8 weeks into disease to avoid treatment-related fluctuations or relapses, early relapse, and she recovered over months. We also repeated the screening for a teratoma, and 8 months in, an ovarian teratoma was identified, which was, after discussion with the patient, in the end removed because she didn't want to suffer from relapse. So we can learn a few things. First, you have to exclude other diagnoses, especially herpes simplex virus encephalitis. If you have a probable disease, you have to start early with treating with immunotherapy. If you think it might be NMDA receptor encephalitis, you might avoid haloperidol, as it has been reported to have an increased risk of malignant neuroleptic syndrome. We use pulse steroids instead of tapering oral steroids, as it seems to decrease the behavioral symptoms in the rehab phase. Especially the rehab doctors will be happy if you do this. And even though the patient has improved, you have to screen them again for tumors, as this might show ovarian teratomas. And we only discussed MRS 0 to 2 as good outcome, but what we do know is that MRS is a very crude measure. It doesn't measure cognition at all. And we did this study in children suffering from anti-NMDA receptor encephalitis, and most of them did quite well in their recovery. But if we look at cognitive testing, attention, long-term memory on the left side, but also on fatigue and quality of life on the right side, what we do see is that most of the patients are on the in the corner on the left lower side, and that means that it's below the average 0. This is Z-score, so Z-score 0 is the average child of that age. So most of them scored below 0. So that means that they have lower quality of life and lower memory function than you would expect from the patient of that age. So we should do better by treating them earlier, treating them better, trying to find ways of better rehabilitation to improve the outcomes of our patients. And if we look at our children, only 2/3 return to the same school level as they attended before becoming ill. So there's still a long way to go. So we go to the third case. This is a 68-year-old male who developed 5 tonic-clonic seizures within a week, and he started on phenytoin. Then he developed rapidly progressive memory loss, disinhibition, and confusion. He started to wander around the ward, and he had waxing and waning somnolence. He had a prostate carcinoma 4 years ago, and he used hormonal therapy to keep this steady, and it was under control. CSF was normal except for a slightly elevated total protein count, and he had a normal MRI. We tested his serum for antibodies, also CSF, and it was positive for GABA-B and KCD16 antibodies. So we diagnosed him with anti-GABA-B receptor encephalitis and started him on steroids and IVIG. We know that 50 to 60% of GABA-B patients have a lung cancer, and we also know that prostate cancer is not a common tumor that causes paraneoplastic syndromes, especially not if it has been 4 years ago. So we screened again, and we found a small cell lung cancer, and he was treated for cisplatin and etoposide, and he recovered very well. He had no seizures anymore and only slight cognitive dysfunction. Unfortunately, 2 years later, his small cell lung cancer returned, and he died due to a metastatic disease. But he had a good quality of life for those 2 years after the treatment. So anti-GABA-B receptor encephalitis was discovered in 2010 by the group from Dr. Dalmau, median age of 60, almost 50% male-female, and half the patients will have lung cancer. A recent study from my group showed that 60% of patients started with seizures, while 40% started with cognitive or behavioral symptoms and developed seizures in the disease course. So if you look at all the symptoms patients develop, what we can see is most patients will have a severe disease with a maximum MRS of 5, which is the highest below death, meaning that they are completely dependent on others. Almost all patients had cognitive behavioral symptoms, could resemble dementia. 90% of patients had seizures, all of them tonic-clonic, but also different types of seizures. And half of the patients had a status epilepticus requiring the admission to ICU. So it's a severe disease with severe seizures in most of the patients. They also developed some other symptoms, but this was not very specific for this type of encephalitis. Importantly, 10 to 15% presented with a disease that was considered to be rapidly progressive dementia, as the seizures were so subtle or absent that it was not considered to be part of an encephalitis. Also, looking at ancillary testing, MRI was often abnormal, but could be completely normal or age-related aspecific white matter abnormalities. EEG was often abnormal, but not always. Lumbar puncture was most of the times abnormal, showing slight pleocytosis, but not always. So the ancillary testing can be completely normal. So you have to be considering this type of disease and recognize the clinical phenotype. Antibodies were present in serum and CSF, but only the sensitivity of commercial CSF was lower, with only 80% of the patients being detected. The outcome, the tumor treatment is essential, as small cell lung cancer is a severe type of cancer with a very poor prognosis, but most of the patients did respond to treatment, complete or partial. All patients were left without seizures, so in that way they did not develop chronic epilepsy, but they could develop could be left with mild to severe cognitive deficits or behavioral symptoms. And in the end, the tumor survival determined the time of survival for the patients. Getting into the last case, which is a 69-year-old male who has been treated for a urothelial cell carcinoma a few years ago by cystectomy, and then he developed lymphangitic metastasis and was started on pembrolizumab. After the second course of pembrolizumab, he developed symptoms of flexing and lifting of the right arm, and also movement of the mouth. A few times it was also on the left side. And 2 weeks in, he also developed leg movements, which caused 1 time a real fall and 3 times a near fall. It only took a few seconds without any pain. It occurred multiple times per hour, and his wife also said that he became more apathic, amnestic, and depressed. When he was seen on the outpatient clinic, he had some of these episodes, as he described, of the right arm, leg, and mouth, which took only 1 to 2 seconds, and also 1 time of the left arm and mouth. He had a normal MRI and a normal CSF, no metastatic disease, and we recognized this as facial brachial dystonic seizures and considered it as anti-LGR1 encephalitis. And his results from serum also turned positive for LGR1, and the VGKC was also positive. So what is pembrolizumab? It's an anti-PD-1 monoclonal antibody. It's an immune checkpoint inhibitor. We know that PD-1, which stands for programmed DEF1, is inhibiting the T-cell response. It downregulates the immune response. And tumors use the expression of PD-1 to escape the immune response from your own body. So it's useful to the tumor. So what is done by anti-PD-1? As it avoids this downregulation of the immune response, it has an anti-tumor effect, but it also activates the immune system. So the most known side effect is autoimmunity. 3/4 of the patient will have some form of autoimmunity, 1/4 of them moderate to severe, and most frequently this is skin, gastrointestinal, endocrine, or lung side effects. If you look at neurological side effects, described in around 3 to 4% of cases, and it might increase as the use of checkpoint inhibitors is increasing over time, with multiple tumors being candidate for this type of treatments. What we can see is neuropathies like GBS or CIDP, myasthenia or myositis, but also cases of encephalitis and cerebellar ataxia have been described. Recently there have been 2 reports by the French group and by the American group from Harvard together with Mayo Clinic to show some of these encephalitis types. So what's important, you have to stop the anti-PD-1 treatment. You start steroids as they negate the effect of the PD-1, and if necessary you can consider more aggressive immunotherapy. So if you look at anti-LGR1 encephalitis, it used to be called anti-VGKC encephalitis, but we now know that this is an outdated term. VGKC was discovered in the 90s, and in 2010 it was shown by both the Oxford group and the Philadelphia group that LGR1 and Caspar-2 are the actual culprits the antibodies are aiming their effect against. LGR1 is a typical limbic encephalitis, while Caspar-2 is a more widespread syndrome, can look like Morvan syndrome, can also show only peripheral nerve hyperexcitability, and is much less frequent. There are many differences between those 2 diseases based on the antibodies, the type of antibodies, the tumor type, the HLA association, and so on, but I won't go into details there. What's important is the patients that are VGKC positive but LGR1 and Caspar-2 negative, the so-called double negatives, have no clinical relevance. This has been described in 30 to even 92% of all the cases that are VGKC positive. So based only on a VGKC result, patients should not be treated. You need more to consider it autoimmune. So anti-LGR1 encephalitis is a disease predominantly seen in male with a median age of 60, although the patients can be younger and older. Tumor association is rare, with only 5 to 10% being present, and has been thymoma, renal cell carcinoma, but also mesothelioma. What we do know is that serum is much more sensitive than CSF, especially if you use the commercial CBA, where it will miss over 40% of the patients by testing CSF only.
Ik weet wel zeker dat het niet meer komt.
You can see a patient.
Omdat ik me gewoon heel relaxed vond.
That was the whole test.
Dat is er.
Komt er nog één?
Nee. Heb je hem? Goed?
Van top tot teen.
Oké.
This was a patient who had a facial brachial dystonic seizure. You could see that his right mouth, but also right arm was moving, and also he had some dystonia of the left arm afterwards. He was completely alert all the time. He even asked us whether we were able to copy this correctly and whether that there would not be another one. FPDS are present in about half of the patients. They're very short-lived and they occur very frequently. They can occur up to 100 times a day, and the important thing is that they occur before the start of cognition and behavioral symptoms in most patients. EEG is most often normal. The second type of seizures are focal seizures. These are even more frequent in anti-LGR1 encephalitis, are a little bit longer. They can be, in a way, atypical, as they could be goosebumps or they could be panic attacks, but they're stereotypical, always the same, also occurring 10, 12 times a day, and also occurring before the cognitive symptoms arise. And those are often detectable on EEG. The last type of seizures are tonic-clonic seizures, present in 2/3 of patients, but only very infrequently and only after the patient already developed the encephalitis syndrome, including cognition. And those are, of course, detectable on EEG. So the disease is typically starting with FBDS or partial seizures, then they develop some memory issues or insomnia or behavioral symptoms, and only later in disease course they have a tonic-clonic seizure and the disease is recognized and the patient starts immune therapy. Importantly, seizures almost immediately stop after immunotherapy, but the cognitive improvement is more problematic and patients can be left with residual symptoms. So it would be important to recognize the facial break-into tonic seizure for the pathology, because then you can start immunotherapy before the cognitive deficits have started and before patients deteriorate. So what are the epileptic drugs to use? In LGR1, what we see is that all treatments are not very effective, but that carbamazepine is relatively the most effective, and this has also been shown for other sodium blockers. Immunotherapy works much better than antiepileptic drugs. These are all the individual patients and their disease course, and I will show it a little bit easier. So the seizure onset on the left side, the purple triangle showing the antiepileptic drugs, and the blue squares showing the immunotherapy start. And what you could see in that patients 1, 2, and 3 developed seizure freedom right after the start of immunotherapy, which occurred in about just over half the patients. 14% it started after a change in antiepileptic drugs, and in 22% of patients it was not very easy to determine what drug actually caused the stop of seizures. This has also been shown by the Oxford group, showing that antiepileptic drugs plus immunotherapy work better than antiepileptic drugs only to stop FBDS, and also that if you don't stop the FBDS, they have much more chance of getting cognitive impairment. So it's important to halt the inflammation, halting the seizures, and also halting the ongoing inflammation causing cognitive deficits. And what they also showed is that if you treat them early, you will be able to reach full recovery, while if you treat them only late, the recovery will be less definite. Importantly, could you stop your treatment after the immunotherapy? And probably yes, if we look at LGR1, NMDA, and GABA B receptor encephalitis. If we look 2 years in, then what we can see is that almost all patients became seizure-free, and most of them we could easily wean off the antiepileptic drugs without relapses of seizures. Of course, if patients do develop seizures, you should be worried that it is actually a relapse of encephalitis, and you should first investigate this before considering it pure symptomatic seizures. So what did we do with our case? Pembrolizumab was discontinued, steroids and IVIG was started. We showed that the LGR1 was present in the tumor, and unfortunately 8 months later he had a recurrence of the tumor, and then we restarted pembrolizumab because it was the only thing that worked for him. We also added 10 milligrams of prednisone, and this turned to be very effective for our patient, keeping the tumor controlled while not relapsing his LGR1 encephalitis. There has only been 4 cases, and I could show for 20 more cases. There are new antibodies discovered every year. I didn't discuss AMPA receptor, about psychosis, GABA A receptor with prominent seizures, and DPPX with prominent diarrhea and weight loss. Take-home messages: they're treatable diseases, they occur at all ages, and the encephalitis can be more of like an encephalopathy, so you have to know the phenotypes, as CSF or MRI will not always be helpful. Tumor treatment is essential. The new treatments, they have great gains, like the immunotherapy, the checkpoint inhibitors, but they also pose new risks. And every patient, even the ones with poor prognosis, deserve a chance because some might improve very dramatically despite the odds. And treatment can be difficult, but is often very rewarding to see those patients recover. And with that, I would like to stop and thank all the people from the different centers, including Barcelona, Philadelphia, Lübeck, but also the Epilepsy Foundation in the Netherlands for their assistance. Thank you very much.